And we'll move directly on to this afternoon's session. We're going to be talking about watchful waiting or intervention, and we're going to be tackling the mitral valve first. So we're going to start with Sanjay Bhattacharyya, who's going to talk about asymptomatic mitral regurgitation, intervening or watchful waiting.
Thank you very much. I'm going to talk about two cases and then do a little review of the literature to help us make a decision. So the first case is a 57-year-old gentleman who was a new referral to clinic, completely asymptomatic, NYHA class 1. On examination, his heart rate was normal. There was systolic murmur to the axilla, and his ECG showed sinus rhythm. This is echocardiogram. So as you can see from the top image, he's got a flail mitral valve, posterior leaflet, with a severely dilated left atrium. The LV ejection fraction is slightly over 58%. And so on the bottom, you have an anterior directed jet of mitral regurgitation, which is severe. PA pressure was about 50, and the ERO is 1.1. These are his TOE pictures, which really could just confirm the transthoracic findings. The flail posterior leaflet, which is nicely shown on the 3D. Annulus is dilated at 4.2 centimeters. So I think this is a fairly straightforward case. So an asymptomatic gentleman with severe mitral regurgitation, secondary flail leaflet, with the ejection fraction of 58%. So these are sort of three options what you could consider. It's meant to be a little bit of an interactive session. So who would perform an exercise test in this gentleman? So Prof. James here. Who would refer for mitral valve repair? So probably the majority. And who would put this person in watchful waiting, follow them up in clinic? So nobody. So the majority of people would refer them for mitral valve repair. If we look at the guidelines, these are the ACC 2014 guidelines. We can follow this patient down. So they have primary mitral regurgitation. They have severe mitral regurgitation with the ERO of more than 0.4. They're asymptomatic. The left ventricular ejection fraction on 3D was 58%, so it fits into this category here. So according to these guidelines, they're class 1 indication for mitral valve surgery. If you look at the ESC guidelines, it's a similar presentation. So no symptoms, ejection fraction less than 60%, so yes. So the ESC would recommend valve surgery. If we look at the rationale behind those guidelines, we can review the literature. So this is a paper from quite a long time ago, which looked at 500 patients with degenerative mitral regurgitation. Patients underwent mitral repair or mitral replacement. And first of all, if you just look at the top right, we look at the survival based on ejection fraction. So the top column here is patients with ejection fraction greater than 60%. Long-term follow-ups of 10 years, they had a survival of 72%. By the time you get to ejection fraction of less than 50%, survival was only 32%. Then they compared these patients to an age and sex matched population, and this is this graph here. And if your ejection fraction is more than 60%, it was similar to an age and sex matched population. Thirdly, they looked at the survival compared to patients with a high ejection fraction and those with NYHA class 1 to 2 in the top, and those 3 to 4. So clearly the presence of symptoms reduces your survival. The same group later on went to look at the effect of left ventricular end systolic diameter. So the smaller group of patients, 266, about 41% had LV dysfunction, which they post-op, which they categorized as an ejection fraction of less than 50%. And if you look at the survival of these patients, if you had a post-op ejection fraction of 50%, at 8 years, survival was about 38%. These are very old papers, apologize for the blurriness of this. However, if you had an ejection fraction of more than 50%, you had a survival of about 70%. And then they looked at pre-op end systolic diameter on the bottom right. And as you can see, there's an inverse correlation between ejection fraction and left ventricular end systolic diameter. So they went to look at the best combination of these parameters. And if you have an ejection fraction of more than 60% and a left ventricular end systolic diameter of less than 4.5, the mean ejection fraction post-op was 57%, while if your ejection fraction is less than 50% and more than 4.5, in this series it was 31%. So that's the rationale for using those parameters. The US guidelines are slightly different, and they have a cutoff of 40 millimeters. And that's probably based on the MIDA study, which looked at people with flail mitral regurgitation. And in that study, a left ventricular end systolic diameter of 40 millimeters was an independent predictor of mortality. The other markers of adverse prognosis, atrial fibrillation. So here we have a study of papers with degenerative mitral regurgitation and atrial fibrillation, where they compared patients' sinus rhythm at index to atrial fibrillation. As you can see from the survival curves, at about 10 years, if you're in sinus rhythm, you had a fairly good survival, with a slightly lower survival with atrial fibrillation. And when they compared that to an age and sex matched population, patients with sinus rhythm had the same survival as age and sex matched population, but those of the atrial fibrillation have much significantly lower survival. And if you look to the cause of death, the majority of deaths in people with atrial fibrillation are cardioembolic deaths. Looking at pulmonary hypertension, again, there's a series of literature. In this study, the criteria for pulmonary hypertension based on echo was mild as between 40 and 50, moderate between 50 and 60, and severe more than 60. And as you can see, the operative mortality increases as the degree of pulmonary hypertension increases, particularly in those with severe pulmonary hypertension. And when you looked at survival, if you had no pulmonary hypertension, you had a very good survival. But if you had moderate to severe pulmonary hypertension, you had an 80% mortality at 5 years. So those are adverse markers of prognosis. So we move on to a second case. So this is a 64-year-old gentleman who had a heart murmur audible on a pre-op assessment prior to cancer surgery. He had curative surgery, and I think this was renal cell cancer. He was asymptomatic, in sinus rhythm, and was referred to clinic. This is his imaging. So, as you can see, he's got bilateral leaflet prolapse, possibly the flail tip of his P2. You've got 2 jets of mitral regurgitation. And the 3D really shows you how you've got your P2 prolapse plus A3 going into the commisure. His ejection fraction was normal at 68%. His left atrial volume was enlarged. Mitral regurgitation was severe, and pulmonary systolic pressure was 38. He went on to have an exercise test. He managed 15 minutes on the bike, 150 watts workload. No real shortness of breath, just stopped due to leg fatigue. His pulmonary systolic pressure was measured on exercise and was 50. So essentially you've got 2 options here, either to watch him or to refer on for mitral valve repair. Who would refer straight on for mitral valve repair here? So we just have one person. Who would watch for wait or monitoring clinic? So half of the audience and about half are undecided. So if you go back to the guidelines, again we have someone with mitral regurgitation, primary mitral regurgitation, ERO greater than 0.4, who's asymptomatic. His ejection fraction is more than 60%. His end systolic diameter is less than 40. So here it says likelihood of successful repair greater than 95% and expected mortality less than 1%, yes or no, yes, mitral valve repair. So in order to make that decision, you need to really ask yourself a few questions about the likelihood of mitral valve repair and what we're trying to do to operate in asymptomatic patients. So the rationale of intervention prior to symptoms, adverse markers of LV dysfunction, will be to improve prognosis. And the questions we have to ask is, what's the mitral valve repair rate? How durable will repair in this patient be? what's the reoperation rate, and what's the risk of surgery in this patient. So you need audit data for that. And the reason repair is better is really long-term survival. And this goes back to 1995. Again, 200 patients with mitral valve replacement and repair. And they looked at survival and compared survival to an age and sex matched population. So here you have the group with repair, and their survival is the same as age and sex matched population, as opposed to the survival of those with replacement, which is reduced. And valve repair was an independent predictor of post-op LV function. So you might ask, what's the likelihood of valve repair? And there are various things you have to look for. One is the anatomy put in front of you, but there's also a question of the centre you're based at. So this is a North American registry of 13,000 patients at 500 centres. And there's great variability in mitral valve mortality, but also in the repair rates. So if you look at the risk-adjusted operative mortality, there's a variety from 1.5% up until about just over 4%. There seems to be a trend towards reduced mortality as your volume increases, but there's still great variability. Secondly, they looked at mitral valve repair. They class this by annual hospital volume. And again, as you see, the mitral repair rate varied from 47% up to 77%. And there seemed to be a link towards hospital volumes. This is old UK data now. And again, it just shows you the variability. So if you look at any particular volume, say around 200 operations, there are some centres at the 50% mark, but others almost at 100%. So there's a great variety in repair rates. So the question is, does durability of a repair matter? And we've had quite nice recent data looking at 1,000 patients with degenerative mitral regurgitation followed up for 11 years. They classified recurrent mitral regurgitation as moderate or more. And if you look at the two groups, the patients with no mitral recurrence and patients in red with mitral recurrence, you see at long-term follow-up, so about 15 years, only a third of those with mitral valve recurrence were still alive, compared to about 60% or 57% with no mitral recurrence. And then they looked at predictors of mitral valve repair. And the major predictors were, one, more than mild MR in the operating room after repair. And the other two major predictors were an anterior prolapse and bileaflet prolapse. And if you look at the long-term follow-up, you can see over 10 years, the difference in recurrence of mitral regurgitation between posterior leaflet, bileaflet, and anterior leaflet. On the top graph, you have the recurrence between patients who have no residual MR in the operating room and mild residual MR. So you might ask the question, does early surgery improve outcomes versus standard care as an overall management strategy? And there have been a few studies. This was recently published. The MIDA study, looking at 6 centres from Europe and the US, is a registry data with about 1,000 patients, or 1,021 patients, without a class 1 indication for surgery. Mean follow-up was quite long, 10 years, and they compared the outcomes of early surgery, which they classified as within 3 months of diagnosis, to routine clinical practice. And they looked at, one, the overall population, which you have on the left here, and 2, a propensity-matched cohort. And as you can see, for both the overall population and the propensity-matched cohort, there's a reduced survival for those with medical management compared to early surgery. The second important feature they looked at was the effect of diagnosis of congestive heart failure, because we know that predicts outcome. And the same was true. So if you had medical management, you had increased risk of congestive heart failure compared to early surgery. And that was both for the overall population and the propensity score matched population. So those are patients with flail mitral valves. This further study looked at early surgery in people with mitral valve prolapse. I think about 10 to 20% of these patients also had flail valves. And it showed a fairly similar thing. So this is 447 patients, 161 with early surgery, 286 conventional. And you see that conventional surgery had a reduced mortality at 7 years compared to early surgery, although the early surgery operative mortality was 0%. And when you look at the deaths, there were 12 deaths in the conventional arm, 5 were due to heart failure deaths, and all those patients became symptomatic and declined surgery due to the risk of surgery. So based on those studies, you might think, does watchful waiting for guideline triggers lead to a poor prognosis? And this kind of contradicts that. So you've got 132 patients with asymptomatic mitral regurgitation, median follow-up of 5 years, and they followed patients up for 12 months or shortened to 3 to 6 months if clinically necessary or there was a change in echo. They were referred for surgery if the ejection fraction reduced, if the ventricular diameter increased, or they developed AF or pulmonary hypertension. And they compared to an age and sex matched population. As you see on the graph here, the survival was no different to an age and sex matched population. Looking at the outcome of people who developed an indication for surgery, most of them developed symptoms prior to that indication, and they had a good outcome of surgery. And if you look at this graph here, for the first 2 years, most people who had an event had a symptomatic event. The incidence of heart failure or pulmonary hypertension was actually very low in the first couple of years. So we have conflicting evidence between the 3 studies I've shown you. They also have differences in the studies. One is a small sample size as opposed to the MIDA study, which had about 1,000 patients. One is a prospective observational study, whereas the other 2 are registry with possible selection bias and confounders. There was meticulous 3 to 6 monthly follow-up in one, whilst the follow-up intervals in the registry studies is unknown and adherence is unknown, and there may be some differences in severity of mitral regurgitation. There are some randomized studies currently being undertaken. I think the UK early mitral study is about to start or may have started, and there's a Dutch trial going on. So in conclusion, asymptomatic severe mitral regurgitation patients with mitral valve prolapse should go for surgery if they have adverse prognostic markers such as reduction in left ventricular ejection fraction, increase in end systolic diameter, atrial fibrillation or pulmonary hypertension. If they have no adverse markers, I think it's a very individual decision based on surgical risk, likelihood of repair, repair durability, and the method of follow-up. And I think I'll stop there.
So we need a surgeon up here to defend surgery. I think John had his hand up first, but quickly followed by somebody up here. So, John.
Well, 2 points which are related. Thanks. So first of all, I think that an exercise test is a very useful thing to do in anybody with valve disease who says that they're asymptomatic, because if they're not asymptomatic, all of this discussion disappears. It has symptoms, and severe MR is a class 1 indication for surgery, so nobody disagrees with that. The important point here is that there's no necessarily binary decision process, in the sense that what you would do, and you haven't exactly said that, but I'm sure you do it, is you include the patient in that. So you would discuss a patient who was genuinely asymptomatic but who had a repairable valve, and you would discuss the dilemma. You'd say that there was this view that you could repair it immediately, or you could watch and wait and see what they say. That's certainly what I do, and I'm sure most of us do that. And some patients will want to have it repaired, and others will want to have it followed up. And you can make a different decision with the same echocardiographic features for 2 different individuals. And I do think that's important in the absence of an RCT, actually, to inform our process, because the guidelines only give 2A. They're not grade 1, class 1 indications, they're 2A, aren't they? So I think we have to involve the patient in these discussions. I think it's terribly important, and follow them up carefully, which you made that point very well. And you have to have excellent surgeons, which I know you do here, but you do have the terrible tragedy of people following guidelines and referring people for repair pre-symptomatic, who end up having a valve replacement, and that's a tragedy. So you have to be terribly careful to adapt guidelines to individual circumstances, I think.
Yeah, we have a...
I'll shout. I'm the other surgeon in the room. I think you've got the wrong question. The question is, to whom should I refer the asymptomatic mitral valve? Because in specialised hands, not necessarily myself, but if you send these patients to Frank Wells, they'll all come back repaired. If you send someone who does 3 or 5 mitral valves a year, you might get replacement. But surely in the modern day, you should follow the advice of David Adams' papers, where you avoid patient-surgeon mismatch. So your asymptomatics and your barlows, like the second one, you send them to someone who does them every week.
Yeah, I mean, I think you need good audit data in your centres to show the durability of these repairs. So if you have that, then I think that would be
The local subspecialisation. In my unit, we have only 2 surgeons who do mitral valve repairs. In Norman's, they've got 3. Many units, there are 1 or 2, and that way, you will know who your local surgeons are if they do lots of repairs.
So that second case was quite interesting because he had a 3 prolapse. He also had commissure prolapse, and there, from experience and from the literature as well, there's very little UK literature. Interestingly enough, we had a registrar who looked at this, and our involvement of the anterior leaflet, involvement of both leaflets is an independent factor for failure. And even commissure leaflet, that's very difficult to repair. And the fact he had cancer. So if you repaired this guy, there's a likelihood he'd end up with a mitral valve replacement on warfarin, needing an nephrectomy. So that's the thought that went through my mind. So I certainly would wait and then maybe see him after he's had his kidney operation.
So he'd already had his kidney operation and was cured, so he had no...
Oh, he did? Oh, I'm sorry. Oh, right, okay.
The data from the Mayo Clinic does show, anterior leaflets do worse than posterior leaflets, and there's well...
So I'll chip in a minute, but we have another question.
Thanks, Simon. That was super, Sanjeev, exactly as I'd expect, considering you spent the last 2 years of your training with us. Do you want to say something about what you think the role of measuring biomarkers is in the mitral regurgitation patient?
Well, we know that raised BNP is an adverse prognostic marker in these patients, but I'm not sure how you'd integrate...
How raised in a mitral regurgitation patient?
I personally don't measure them because it's not in the guidelines and it's not something we have easy access to, but it does have an adverse prognostic marker. But I'm not sure how you'd use that. It may help you with a borderline case, but personally I don't think it's that helpful.
So any other questions? So I guess I've got a couple of observations. The first is that if you look at the data, that MIDA data from the 6 centres, from the Mayo Clinic plus 5 centres around Europe, and it's clearly non-randomised. It's collected at varying time frames in each of those centres, but it's over about 20 years. And if you start to kind of dissect that down, I think when I worked it out, it's 6 or 7 patients per centre per year. Now, it's hard to believe that for centres of that size, that's all the patients with severe mitral regurgitation that's going in. So I think there are flaws in that data. It doesn't come across as being a prospective series, and they're highly selected patients. They're only flail leaflets. And I think we've all come across situations where we all know the answer before the randomised trial's done. The randomised trial is done and the answer is different. Renal artery de-innervation being an obvious one. I'm a big proponent of trying to do a randomised trial of watchful waiting versus surgery, and the CI on the UK trial, which is at the moment run into the sand because we've had some difficulties with a trials unit, but I still feel we do need a trial for this because I'm not at all convinced that the answer is as clear-cut as we think it is. There's no doubt that in really good surgical hands, and if you look at the results from the Mayo Clinic and Rakesh Suri, they are outstanding. They're really outstanding. And Frank Wells being another example of somebody who devotes a major amount of time to mitral valve repair, and David Adams, these very complex valves can be repaired. But those results have never been reproduced in a wider range of centres. And I know with a pretty good degree of accuracy what our local surgeons are capable of doing, at least as far as does the patient come out of theatre with an intact valve. Now that's not the same as do they have an intact valve 5 years down the line, and there's actually very little data on that, and that's the real question. There's no point in having a great valve for 3 months that then falls apart. So there really is a need for more data. Sadly, the Dutch trial isn't taking place anymore because they've been struggling to recruit because people in Holland know the answer before the trial. And certainly in the US and most parts of Europe, they know the answer before the trial. And I think the UK, if we can do it, is probably the only jurisdiction where it will genuinely be possible. So we hope to resurrect UK EMST, and I will be banging on the door of a number of you if we do, requesting you to recruit patients. So that thereby ends the plug. Does anybody, are there any more questions or comments at all? Or one further, yes.
Just one or two observations. I mean, I think at the end of the day, we don't know at the moment what is better. And I agree with you. It's not straightforward, and I don't think the answer will be straightforward. I mean, for instance, another thing is, what do you do with the elderly patients? What do you do with, what do you call elderly patients? What do you do with a 70-year-old who has a flare leaflet, who's asymptomatic, or 75, or 80? Do you also go be aggressive and say early surgery is better than watchful waiting? I think that is not known, for instance. And I agree with John Chambers. I think you have to have a discussion with the patient because we don't know. I mean, I quite like the Roseneck paper because I think that's a pretty sort of robust paper which has really compared true watchful waiting. I think all these other papers that have come out positive in favor of early surgery, I think you will see they are often flawed because they haven't done true watchful waiting, as you said. And I mean, what I quote, and I don't know if that's correct, I think the Roseneck paper, 50% of patients after about 8 years will have an indication for surgery. I think that's roughly about 45, 50%. So, that's something that I say to the patients. Well, 50% after 8 years, then you have a discussion with the patient. I mean, that they might have observation. And I would very much support a randomized control.
I think your point about the watchful waiting is extremely well taken, and inevitably in a series where the primary focus of the study is surgery, it's very unclear, particularly from the Korean paper, to what extent the people who were not operated on early were systematically followed up. And that's certainly true of the Mayo Clinic. And the Mayo is a phenomenal institution, but basically people come to the Mayo from everywhere, all over the world, and in terms of the medical follow-up, they may then go back off to, I don't know, Peru, Brazil, and be followed up locally to a varying standard before they come back for their very, very good operation. So it isn't all that clear-cut. Okay, thank you very much again. So we'll move on now. So we've dealt with mitral valves. That's done and dusted. The answer is we need a randomised trial. Thank you very much. And